see you guys. So welcome to the George Blue Spruce Hero Healer Luncheon Series. George was the nation's first ever American Indian dentist who became so in the midst of plenty of barriers to keep him from doing that. So we were excited to name this series after George. The purpose of this series is to inspire you, to refresh you. Most of you, hopefully coming to ATSU, all of you came into the health professions with this desire to make a difference in people's lives, to deal with those who need help the most, and to be the one who can step in and help. And unfortunately, the rigor of health professions school can beat that compassion out of our healers. And this purpose of this is to reinstitute the passion. And what we want to do, and what we do is put in front of you individuals whose very lives can serve as an example for you. And you can say, I could do that. I could do something like that. So this is my friend Winston Wong. And Winston has spoken every year since we've opened SOMA. Why? Because he's been the most requested, please have that person come back, speaker, because the students and the faculty here connect with him so well. So Winston, as you guys read, has accomplished quite a bit in his life. He's been working at a health center his whole life. It's not his full-time job, but at times in his life it has been that. And he's been a leader in HRSA, the Health Resources and Services Administration for Region 10. He was a clinical leader for that. He's currently at Kaiser Permanente's community benefit, and that is their we're going to give money away arm, right? So he's the medical director of that. And I shared with you that he was San Francisco Chronicle's Father of the Year. What I didn't share, and the email went out, is that his name comes up pretty regularly. It has come up consistently over a 20-year period as someone who might be the Surgeon General. And so I'm really proud to get to know Winston, and let's welcome him.
Thanks, Gary. So a couple corrections. I haven't been at FQHC my whole life because I wasn't born there or anything like that. I was born at Kaiser Permanente, San Francisco. But yeah, I've actually been with community health centers for a long time because I was part of the same community health center where I see patients as an undergrad. So as an undergrad at Cal, I was volunteering at the clinic in Oakland, Chinatown. So great to be with you. It's actually, for me, it's something I really look forward to. Parenthetically, because the Giants do spring training down in Scottsdale. Gary knows my stick. But also because it's just really so important. I mean, it's really an honor to be able to share with you some thoughts because every year I think the ante is ever more important because every year I think we see that there's actually, although there's a lot of people still applying for medical school, PA school and stuff, there's a lot of young people who are turning away from the profession for a lot of different reasons. And I hate to say this because but I'll acknowledge it. They say that 25% of all medical students have clinical depression at any given time during their 4 years. It's really very distressing to hear that. And so I'm kind of trying to exercise preventive medicine in sharing with you and eliciting kind of your thoughts and feelings. The other thing about it is that even after people enter into medicine, for example, the latest report suggests that 40% of primary care physicians in their 50s are really feeling burnt out. I'm in my 60s, so I don't know where I am right now at this point. Actually, did you see the picture outside the door? There's like this little picture. That's not me. It's someone that I knew about 15 years ago. But I did want to kind of start off because you don't know what stress is. It's really stressful to speak to about 50 really intelligent young professional students at lunchtime, okay? So not to mention having, the lunch with kind of the food coma that comes along with that. So I will move around, and I want you to participate in this discussion because in many ways it's only valuable in terms of how you're able to think about where you are. So I want you to think, just for maybe 10, 15 seconds. Hopefully this is not a distant memory for you. I want you to think how you felt when you first learned that you got accepted to the AT School of Medicine, AT School of Osteopathy for Physical Therapy, AT Still School for, I don't know if we have any dental students, but we have you as health professional students here. Just think, get yourself back into place. Used to be we used to tear open the envelope. I don't know if that happens anymore. But when you clicked on the AT Still School, and they probably don't put on the subject line, congratulations, right? Just think. Does it feel that far away from you? What happened that day? Is that something that you kind of carry with you? Because you need to be there sometimes. You need to remember what it meant to you. So you spent 10, 15 seconds thinking about this, right? Now, I want to see if any of you are willing, brave enough to share with your classmates what you felt that day and how you look back at it. Anyone want to share it all? Okay, please, thank you. And if you could identify yourself for me as well as your classmates, unless you know everybody in the room. Aloha.
Aloha.
Are you from Hawaii?
Went there for undergrad.
Oh, great. UH?
Yep.
Oh, great.
I'm Sam. I'm from Soma. So the day I got accepted, I was actually rock climbing with one of my classmates in this program. We knew each other prior to this program, and he.
Over at UH?
No. So I went to Touro University last year in Vallejo for my master's. And so I was rock climbing with him, and I kept my phone on me because for Soma they give you a phone call. And he had my phone while I was rock climbing. He's like, "Hey, come down! Like someone from Arizona is calling you."
Yeah.
And so I was like, "Oh my gosh, I don't know what to expect." And then I just remember feeling really happy, and then I just started crying.
Oh, that's beautiful.
Yeah, and it was just really motivating because all my hard work.
Yeah.
I put into trying to get into medical school finally paid off.
Wow.
Because it was my second time applying.
Yeah.
So.
Yeah. How long ago was that?
That was April of last year.
April of last year, so about 10 months ago.
Yeah.
Still remember the feeling?
Yeah. Yeah.
Great. How about someone else? Over here? Oh, okay. There's a great volunteer.
So,
what's your name, sir?
my name's Andy, physical therapy department, and
Like a physical therapist student.
thank you. I remember when I applied at AT Still, I got an interview, relatively quick, with the assumption that I'd probably get the turnaround rate pretty quick as well, and it took 6 weeks before I got an email. So, they told me at my interview, you'll probably find out in a week and a half. So I was like, man, I'm at the bottom of the pile. What's this? What did they not like me? And I think I was at work or something, or at a stoplight. And then I just got an email, and it said congratulations, and just the stress from my shoulders just, lifted up. I knew I was getting into a school. And this is the first one I got into, so.
Oh, wow.
It felt good.
Yeah.
I know that I was going to get into
Yeah. What did you do that evening?
Might have had a beer, but I'm not sure.
That's what I'm really curious about. Okay, let's get one more interesting story. I'll tell you, a few years ago I heard a really interesting story, but I want to hear this one too. What's your name, ma'am?
My name is Ariana.
Okay, Ariana.
And the day I got accepted into Soma, I was actually getting off the plane to go to a different interview in Tampa. So I got the call, and I was super excited. didn't even show up to the interview. I took the bus to Miami
that's right.
and visited my sister in Miami. Just blew off everything else.
Yeah, that's pretty cool. So, you know what? I think it's common experience. It's like the day you get accepted, right? Doesn't it feel pretty cool to tell everybody else, I don't need to interview you anymore. I already got where I want to go. So that's cool for sharing that. You know, it's really interesting. I think one of the funniest stories I got from this group was, and maybe you remember this, Gary, one of the students said she was I don't know, she was a mother, okay? And she said that when she got accepted to medical school, she was so excited, and she had like a 7-year-old son, and he got so excited, he started taking his clothes off and running around the house. I thought that was like a funny story. That's pretty cool. Did that happen to anyone? Maybe you took your own clothes off, I don't know. No, I won't go there. No, so it's really cool to share that. And I do remember when I got accepted to medical school, and you know, the thing was, it was such a weird story. I didn't get the call. Somehow or another, back in the day, they called my parents' home because I put that listed down. And my father got the call, and he had this big grin when I came into the house. And he told me, actually, that I got accepted to the UC Berkeley UCSF Joint Medical Program. So the thing is about that call and how you feel, and I felt like I was walking on clouds like for at least 36, 48 hours because, you know, what did you call yourself before you got accepted to medical school? I'm a pre-med student, right? You kind of say, I'm a pre-med student. But then afterwards, then you say, geez, people are going to say actually Dr. Wong after a few years, which is pretty amazing. So congratulations, especially for being part of AT Still's mission, and particularly Gary's program with regards to connections to the underserved and community-based care. Now, having said that, you guys got accepted, right, about 10 months ago. And congratulations, you're going to have like $200,000 worth of debt. And you know, you get to spend 10, 12 hours a day in the classroom cramming stuff in your head, right? Let me ask you this. What do you really want to get out of this education? What do you really want to be? Why did you invest so much time? Why are you putting yourself in debt for $200,000, $300,000? What would you tell AT Still? What do you want from them? You're the boss. You pay the bills. Someone pays the bills. What do you really want? What would you say at the end of your 2-4 years that you want out of the school? Gary's listening, right? Okay, this here. What do you really want? You want to learn what you want to be to know. You want to share something, right? You raised your hand. I'll give it to you anyway. What do you want? And what school are you in?
I'm in the physical therapy
Okay,
program.
what do you really want?
A quality education and good opportunities to reach out and branch out of my comfort zone. And,
Okay.
Yeah.
When you say education, what does that really mean? Do you want to be able, you want to be able to be like, really know the ins and outs of physical therapy?
Yeah, I'd like to.
Okay.
Mm-hmm. I mean, I myself want to be a rural physical therapist.
Okay, a rural physical therapist.
Yeah, I would like to know a majority of every part of physical therapy. So.
And how does that fit into the rural adjective? Physical therapy different in a rural versus urban versus suburban?
In a medically underserved area, I'd like to have a more broad breadth and depth of physical therapy. So.
Okay, because you feel like you won't have as much professional colleagues to provide support.
There's not really specialties in certain underserved areas.
Okay.
So, yeah.
So that's really interesting because what I'm hearing from you probably could have gone to physical therapy school in downtown Los Angeles, right?
If I got in.
Are you from California?
Yeah, I'm from California.
From Southern California?
No, I'm from Northern California. I mean, I went to school at UC Santa Cruz. So.
Oh, okay.
Yeah.
Okay. Very, very close to where I am.
Mm-hmm.
So when you say that you really want to work with the underserved and rural communities in physical therapy, is suggesting that you're looking for something very specific. Because physical therapy as a body of knowledge is there across dozens of different campuses, dozens of different schools. What are you saying about your goals and what you want to do?
I don't know. I'm on a lot of medicine right now. So
You're what's that?
I'm on a lot of medicine right now, so my brain's a little slow.
She's on a lot of medication. Okay. Marijuana's not legal in Arizona yet, is it? Come to Colorado. Okay. No, I'm not trying to be against. I'm just trying, because I think it's a really interesting question that I pose to all of you, because medical knowledge, physical therapy knowledge, is not monopolized by A.T. Still School, right? But what you're trying to extract, and you think about what you got in the mail, you're trying to optimize what you want to be as an individual, right? To be a healer. So, of all the different places you could have gotten education, you got it at A.T. Still, or you're getting A.T. Still. And I think what I would suggest is knowledge is one thing in terms of just the body of knowledge that we're responsible for. It's another thing to think about what does it mean to become a physician, physician assistant, a physical therapist in terms of caring for people, right? So how do you really think A.T. Still School is going to teach you to care for people? Because I could say, and we'll go through an exercise, the knowledge is pretty much at the fingertips of any individual who has a smartphone now. Isn't that true? Okay, we'll do an exercise like that maybe a little bit later. So, if we're talking about caring for patients, caring for people, why do you think people actually want to come see you when it comes right down to it? Why would they spend part of their day? Why would they pay you or have the insurance company pay for them to see you? Is it, tell me what you think is, if you had to extract down the barest reasons as to why people want to see a healthcare professional, a physician assistant, physical therapist. Why do you go see a physician assistant, physical therapist? And you have to get it really down to its core. Any ideas? Yes, I'll throw this to you. You can speak loudly.
Feel better?
They feel better. Okay. Do we go see? Yes.
Make sure they're okay.
Okay, reassurance. Let's get down to, now actually, I'm going to call you on this. If you want to feel better, or you can say, I want to go see the doctor today because I want to feel better. Do you do that? Okay, because you're sick. Okay, so now that's a qualifier. You're saying, when I'm not feeling well, then I want to feel better. Okay. How about the emotional state that you tried to get at? What is the emotional state in which people will take part of their day to go visit a healthcare professional?
Well, they want to feel comfort.
Comfort. Right. Comfort is a key element. Comfort is something that is not found in any medical book. Think about what you're learning. What are you actually studying right now today? What pulmonary? All right, pulmonary. Okay. You're learning about what vital capacity. What's restrictive lung disease. Is that what patients are seeing you for? No. Okay. So caring is a big element. What are the reasons do people go see a doctor? And you probably have people in your family that are resistant to seeing doctors and PAs, right? But they eventually do. Why? Help that you can't get. What help can you not get online? Okay, medication and procedures. Because they feel, put it in a feeling sense. What are they feeling? Uncomfortable. We talked about comfort. What other things? Scared. Anxiety, right? But tell me what really drives people to go see a professional, healthcare professional. What really brings people say, I'm going to go there like now? What's that? Desperation. That's desperation because of what?
Maybe they waited too long.
They're afraid that something bad's going to happen? Okay. What was the last time any of you went to see a doctor? Okay, and why? Why did you go? I mean, I don't want to get too personal because we're getting to HIPAA, but I want to explore emotionally why you went to go see your physician, if you want to share that. Yeah.
We both went for 2 days ago. So,
Yeah. Why?
Because we were feeling really.
You wanted medication,
We were feeling desperate.
and you got medication.
Yeah.
Okay. So the doctor's the nearest drug dealer.
Yeah, basically.
Yeah. Oh, okay. Wow, this is really deteriorating.
No, we couldn't feel better with the meds we were getting, and I don't know, over the counter kind of stuff, and so we needed something for someone to tell us we didn't have the flu recently.
Okay.
We wanted to know.
Okay. So we've heard a couple of emotional states. One is being uncomfortable, desperation. Does someone say fear?
Yeah, we didn't want to miss.
Fear?
Fear.
Real fear.
Oh, no, not that fear. Real fear of flu.
Okay, real fear. But I think the other thing, I'll just blurt it out. Pain. You know, don't you think that most people eventually go see their healthcare professionals and say, I can't live with this anymore? Especially those that are resistant, right? Pain. And pain is both physically manifested, right? That sprained ankle is just killing me. Or I think I broke my finger playing basketball. But there's as much emotional pain that goes into seeing a healthcare professional as there is physical pain. So if we get down to these various core emotions, pain, insecurity, comfort, anxiety, I think you have to ask yourself, how am I being trained to care for people when they come for these days? So I think probably AT still does a really good job of it, but they don't do a perfect job of it. And in fact, think about what you're learning right now. There's a great deal of emphasis that you make sure that you do the right kind of checking, and that you want to impress your professors by being an encyclopedic bastion of medical knowledge. Because if they ask you a question and you didn't come up with the right answer, you're going to look dumb, right? But is that what patients really are looking for? Patients want to have the security that you know the subject, but they really value how you can address their pain, their insecurity, their discomfort, their fear. So how do you do this? How do you become skilled at identifying how you are able to address these issues? How many of you really think that you're going into primary care? Only 1 out of 70? A couple. Okay, didn't want to put anyone on the spot. So this is the way I think about it. when you think about what you're going to be trained to do, what are the aspects of what you bring to that special moment when you're caring for people that you have seen in other parts of your life? Okay, think about it. And why you're here at AT Still, concretely. Okay.
Client-centered care and a therapeutic relationship.
I'm sorry, you have to speak out. The microphone.
Client, is this, okay.
Yeah,
Client-centered
speak it
care
up.
and a therapeutic relationship.
Client-centered
care
care.
and a therapeutic relationship.
Okay, so where do you see that in a non-medical situation?
So I would probably, I guess, I don't know.
Oh!
I don't know, I've only ever seen it, I guess, on fieldwork and stuff.
Excuse me?
I've only seen that in fieldwork and
Field work.
PowerPoints and stuff.
Oh, PowerPoint, okay. PowerPoint.
We work on that, I guess.
Okay. All right. So I'm just thinking, what do you think, this is what it means to be a professional, right? What does a professional, healthcare professional mean, and what are some unique characteristics that we bring to the table that you have seen in non-healthcare professions? Uh-oh, I'm doing really, I'm providing you with real challenges here. Okay. Who do you go see if you have a really important technical question that's very important for some situation in your life? Who do you go see? Or maybe you see anybody, you just go into Google.
An expert,
An expert. What kind of expert?
depending on the problem.
Okay, depending on the problem. Give me a problem that you might have sought expert opinion.
Like, a lot of times, the system we use for exams doesn't work, so I go to tech support to get it fixed.
Okay. How about someone that is more than just, I just want to answer, but I need some advice on a technical issue? You think about who brings that to the table? A coach? Okay, maybe that's a good one. Think about, now you guys may be a little bit young for this, if you have tax questions, maybe you guys don't make enough money to worry about it. But you will. You want to go to someone who's really trained in terms of accounting or legal issues, right? So my point being, there is a body of knowledge that's undeniable within medicine, which is technical, highly technical. Because if you went and just went on the street and said, you know what, I want to talk to you about some nephrology today to the person on the street, I don't think they really would want to talk to you, right? Because it is a highly trained area of knowledge. So if you think about that, there's certain other professions, right? Accountant, I mentioned, an attorney, right? Because the legal stuff, most people, is too obscure for people to understand all the legal ramifications of a particular thing that you're trying to do. Okay, so there's the skill set. Now, what is another profession that when you walk into the room, a person is almost able to reveal anything about their life? So this is what happens with the magic coat. What is the magic coat? The magic coat. Okay, my pocket. Oh, is it working? I think so. Okay. Okay. You can hear me, right? Okay. When you go into a room with the magic coat, people will tell you all sorts of things that they won't even tell their spouses or their loved ones, right? Is that true? Have you said anything to your healthcare practitioner that you didn't want anybody to hear besides your healthcare practitioner? Think about that. Who else would you be able to do that with? Priest. Yeah, I think, so there's an aspect of being a healthcare practitioner which is like clergy, in that we're supposed to honor the truth-telling and the confidentiality. Right? So you have to really be able to capture what that means for people. People will hide secrets with almost everybody they see until the magic white coat comes into the room. Sometimes it works, most often it does, but you have to be able to recognize that as a really important component of what you bring in. Now, the third aspect, which I usually puzzle people about, is who do you see on a regular basis that you are able to develop an ongoing, intimate, but safe conversation with? Do you think? Peers? Okay, peers, you check in with your friends, but I'm talking about a profession. Or a professor? Oh, I didn't have those professors. No, it could be, you might have a great relationship. But who would you see throughout, on a regular basis, every 2 months, every 3 months, every month, that person says, how are things going? What have you been up to? That's cool. I hear what you're saying. A hairdresser. And so do not, your hairdresser knows a lot more about your life than 90% of the people in your life, right? Prove me of that. You look well groomed. But that's a good one. I think it is the hairdresser. Because, it's very interesting. We have this relationship with the hairdresser. If you have a regular one, it's almost therapeutic, right? You think about it. You sit in the seat, and then they start working on you so you can kind of get distracted. And they usually ask you, how are things going? You probably even told them that you got into medical school. You probably even told them you got into PhD school. And they probably ask you, how do you feel? How do your parents feel? And they might have said, are you having problems with your boyfriend, your girlfriend? And then you said, and we're trying to do this. It's amazing that there's an aspect of a therapeutic relationship, because what happens, there is some security in knowing that there is a sustainable, non-judgmental relationship that is occurring in that instance. Even though for a guy, the haircut may only take 20 minutes, for a lady it might take an hour or something, but that regular check-in actually brings a lot of security. So it's interesting. I try to point out to you that we talked about the emotional states that patients bring into you. They're looking because they're scared, they're in pain. And then what are you bringing in? You're bringing in a professional body of knowledge that is highly select, that is not very accessible for the mainstream, right? Let's talk about nephrology. Let's talk about Still's disease. Let's talk about thalassemia. And on the other hand, you're also bringing in that level of confidentiality and trust, as clergy people do. And the thing about the regularity of the visit and the regularity of checking in and being non-judgmental. So I was wondering if AT Still actually has a class for you that talks about being a hairdresser and being a clergy person or being a technical expert. It does, actually. It should be doing this stuff because it is as integral to your education as anything that you're reading in your books, right? So, let's see where my time is. Because I wanted to also give you a little bit of practical advice and kind of how we're not actually doing this in our medical education. Okay. So, have you all presented to your professor a clinical case? Can I see a raised hands? Have you all, no, you haven't presented yet? Okay. All right. So, how do you usually present a case to your professor, to your clinical instructor? What do you usually say? You go subject, right? Subjective, objective, assessment, and plan. So, right? They're still doing that. I hope so. It's been a few years since my training. How many of you are used to saying a 36-year-old female presents with lower abdominal pain of 3 weeks duration? Does that sound pretty good? You're used to saying that? Okay, so what have you done with regards to how you're presenting your patient, who you are caring for? What have you done? Excuse me? You have removed the personal connection in what way? Concretely. What's wrong with what I just said? Is there anything wrong with what I said? You don't think anything's wrong with what I said? No. Okay, you're accepting of that. 36-year-old female presents with 3 weeks of lower abdominal pain. Okay. All right, we'll accept that. Anyone else have a different opinion? Her name?
It depends on who you're presenting to.
Does it?
Yeah.
Tell me more about it. She says, here, let me hear your thinking. I'm really interested in your thinking.
Well, it depends if you're presenting to someone that has, like if you're following HIPAA, like you can't reveal too much about your patient.
What can you not reveal?
I don't think a name would be appropriate.
Okay.
But you can, if you make it anonymous and create a generalized patient out of it, so you're looking at more the clinical side, that's what's going to be pertinent to present to them because that's how they're going to help you.
Okay. So if you're presenting to your attending, you would leave out the name?
A little closer.
To my attending?
Yeah, get closer to your
No. No?
You went?
Keep the name?
Okay. Okay. This is what I would point out. Okay, here, please. Why don't you pass it to your classmate behind you? What's your comment?
Is this?
Yeah.
Okay.
Speak loudly and get closer.
I mean, I know where Leslie's getting at. It's like the way we are expected to talk about our patients is that way to our attending. So we're supposed to say, so-and-so, 36-year-old female presents with blank, blank, blank. But you're right, it dwindles down the patient to just a simple, like bare bone frame, I guess.
Yes.
Of a patient, rather than maybe saying she does this and she does that and we had a really nice connection or something like that. So that gets lost in the presentation. Yeah.
So this is common across medical schools and health professional schools to present it this way. And there must be a really good reason why.
It's quick. Concise.
Maybe it's because of standardized format. Maybe it's also because we dehumanize patients. If I said to you, this is a 36-year-old woman, mother of 2 children, who has a single mother household, who complains of having unrelenting lower pain in her abdomen for the last 3 weeks, and she feels that she's being disabled because she's unable to go to work every day. Does that add to your opportunity to be a clinician? It does, I think.
We are expected to do that here.
Okay, great. This is reassuring. I want you to be very cognizant of the terminology that you use, because the terminology and the way you talk about people that come in with certain needs is going to frame how you care for them. Because basically, I could say a 36-year-old female presents with lower abdominal pain. Frankly, I could say that about an elephant. Right? I could, right? Because we have objectified the clinical case so that a female ceases to become a woman, a female ceases to have any role in the community and her family life, and a condition should only be assessed relative to physiologic or anatomic manifestations. So think about just the terminology that you use, because what's going to creep into your health professional education is subtle ways of actually emphasizing your technical expertise to the detriment of your expertise in terms of being a caring human being that takes care of people. Right? So there are many ways that this comes across. How many patients are you going to see today? Well, I'm going to see 20. I got 3 immunizations, I got 4 rashes, and I got 5 abdominal pains. We start to talk this way in terms of trying to compartmentalize our ability to be able to care for people. We think about them as cases as opposed to people that are coming to us to seek the kind of comfort, pain relief, security that really is at the heart of what we really need to do as care practitioners, right? So I wanted to point that out to you. The other thing that happens is that we all become very rushed. And I think typically, it's happened to me, it's like you're finished, so to speak, for the day after seeing 20, 25 patients. And then there's a patient that comes in at 4:50 p.m. And you say, how am I going to get out of this one so I can make softball practice by 5:30, something like that. And you have basically said, I have things that I want to do that supersede my interest in being a totally focused healthcare practitioner, professional clinician. Because what you've done is you say, this is number 26 of the day, as opposed to understanding, you know what? This patient probably really resisted coming to see the doctor. And maybe they had a lot of pain, and it took them a lot of time to get into that door. Maybe it was also because that elderly lady, she circled the date on her calendar saying, visit Dr. Wong on February 28th, 4 p.m. She made sure her grandchild was able to pick her up, and drive her to the clinic, and then she got there a little bit late, but you know what? You don't care about that. You care about making sure that I get out of here because I need to finish. Right? And we communicate this. I'll get to you in a second. How do we communicate this? Is this a thought back here? How do you communicate the fact that it's like, this is number 26? Yes, right? So there's a lot of body language and rushing. Very good. Like, sometimes it's not so subtle. I close the door. I'm holding that handle because I want to get out of this. People do this unconsciously. I want to stand up because I can get out of here fast. I don't want to sit down. Or you get right into the computer and say, okay, you're 78 years old, you're here, okay, what do you need? There's very little eye contact, and there's very little listening. Because you want to finish that visit. Because it was number 26. And you thought about you being a tired clinician 26 patients later, as opposed to you being maybe the only physician that this patient has seen for the last year. So we get very desensitized to the amount of messaging we give with regards to what it means to be a healer and what it means to be a caregiver. So did you want to share something with us? Oh. Jeez, but that doesn't get you off the hook either.
I just want to point out, so I'm from occupational therapy.
Yes.
And we have been talking a lot about OT and primary care lately.
Yes.
And so just a way, OT is a lot more, not a lot more, but like we focus a lot on client-centered and what the patient needs and wants. And so there's this movement that OTs can look in primary care. So if the physician, they have a lot of patients to see, like the OT can go in with the physician, and the physician can like check like what's going on, and then they can go see the next patient, but the OT can like actually stay in the room, talk to the patient, see what the patient wants and needs, like have that conversation, because the physician is obviously a lot more fast paced. And so I just think that's like a really good way to kind of like fit like OT more into that primary care and be able to like sit down and actually ask the patient what they want and need and not dehumanise them.
So you got all the medical students very envious of what you're going to do in the future.
No, we've just been talking a lot about OTs like going into primary care.
Well,
I think it's awesome.
that's very encouraging, and I do think you're part of the healthcare team. And part of the challenge is, even with ACA, and we can get into policy stuff, is the fact that as we are trying to create efficiencies within healthcare delivery system, there's some aspect that we might be getting lost with regards to what does it mean to be a caregiver, as opposed to what it means to churn out visits. So I have about 15 more minutes, and I wanted to maybe do this exercise and then also share with you a story. So, how many of you know what alpha thalassemia is? Okay, can you tell me a little bit about alpha thalassemia?
It's a blood disease, and it's basically when you have, if I remember correctly, like you have a deficiency in like a blood factor.
Okay, so everyone get on their phone. I want you to look up alpha thalassemia, THALASSEMIA, alpha thalassemia major, signs and management of. I'm sorry? Okay, first one who can give me some answers, get a prize. Alpha thalassemia major, signs, symptoms, and treatment.
They say the signs and symptoms of alpha
Thalassemia.
It's jaundice, fatigue, a pronounced forehead, gallstones, and hypertension, but that's mostly just.
Okay, great. Okay. Yeah.
They said for treatment, it may not need any specific treatment, but they do have severe, and then they need a lifelong transfusion therapy.
Okay, great. So you guys did that in 1 minute or less, right? That's pretty good. There's probably some people who do it faster than 1 minute. Because, so what's the nature of medical knowledge? It's basically very accessible to almost anyone that's proficient with a keyboard and a smartphone, right? Now let me tell you the story. So I had a patient who was about 22 years old, immigrant from China, who had received about a 6th grade level education. She had alpha thalassemia as a routine blood check in her prenatal state. And then we said to her, we need to check if your husband has also trait, because it's genetic recessive, has to do with the hemoglobin chains. And if the husband and the wife, the parenting couple, I should say, both have the genes, there's a chance that there's a really deleterious effect on the infant, right? She said to us, I don't speak any English. My marriage was arranged. My husband works at a restaurant 6 days a week, 10 hours a day. I don't think I'm going to ask him to come in and get a blood test because he's going to think there's something wrong with me. Something wrong with me in terms of carrying a child. So it's very interesting that if you get down to it, her identity was very much wrapped into being a mother and being a parent and providing a son or a daughter to her husband. This is a very torturous story. We asked her to bring her husband immediately. It wasn't until 6 weeks later that she literally dragged him in to get a blood test. And he says, I don't know what's the big deal. I am healthy. I've never had a sick day in my life. Why are you saying that I need to get a blood test? Tried to give a lot of reassurances. It's just a check. He did get the test, and he was also alpha thalassemia. You get double dose alpha thalassemia, there's about a 1 1/4 chance that you have a condition for the infant called hydrops fetalis, which is basically stillborn and or birth dying within the first few days of life. But you don't know how to check this in utero except by doing, I'm trying to remember whether it was amniocentesis. I think it was amniocentesis that time, and to extract cells from the amniotic fluid and then be able to look at DNA samples from the cells. We said to her, we think you need to get an amniocentesis right away because time is starting to tick. And if we don't get this baby diagnosed, it's going to be a time where we cannot terminate the pregnancy. So time is ticking. And then what did we tell her? We said, by the way, if you get amniocentesis, there's about 2 or 3% chance that even if your baby's healthy, you'll have a spontaneous abortion and lose the pregnancy. So we gave a very legitimate, logical, medical explanation as to why we would advise this. So she tells us at 20 weeks pregnancy, why are you telling me to submit myself to amniocentesis, potentially lose the pregnancy for something we don't even know whether it exists? And by the way, I'm starting to feel my baby move. So she actually came to a crossroads. So she says, look, you're telling me this, you decide what I should do. How many of us would learn this from what you Googled with regards to how to care for a patient with all these conditions and all these social pressures on her being a mother? It came down to the fact that when we finally did the amniocentesis, this baby indeed had hydrops fetalis. And it was already past the time of a voluntary termination. She gave birth to a baby that died within the first 24 hours of his life. And that family was never the same. Did we do all the things that were described in medical literature? Absolutely. Were we able to navigate this person's issues to provide the support? I remember very specifically, we brought in a genetic counselor. The genetic counselor was taking these balls out to demonstrate what a recessive and dominant gene was in English with the interpreter. But I saw that and I said, this is not what it means to care for people. You might have felt better that you explained what recessive and dominant genes are, but we did not address her questions. And I have to tell you, I was in the middle of this situation, and I never felt so powerless. But you have to reference what it means to be a caregiver. Let me end with another story, which I hope gives you a hopeful note to think about where you want to be after your practice. So the old adage is our patients are our best teachers, right? And I always recall this patient, because she taught me so many things. She was like an 82-year-old Chinese woman that had immigrated from China to the United States just within the last 5 years. And I don't know if you've been in Chinatown. So you see a lot of these ladies. They actually carry their grandchild on their back, even though they're 82 years old and they got crooked back, and they carry vegetables. She really wanted to be part of her extended family and to be productive. So she actually told me that she also took up a side job by cutting threads at a garment factory. And she said, well, I get 25 cents a piece for every thread, every garment that I kind of look over. And I said, why do you do that? It's so meager. And then she says, because I want to be productive. I want to contribute. So this is Lee, not her real name. I put her on arthritis medicine. And she had some hypertension as well. And she was the sweetest lady, even though she was, I don't think she even went to school ever. But I got this call sometime on the weekend and said, you know, your patient, Mrs. Lee, she presented into the emergency room. And she's got gastric bleeding. And the first thing I thought was, God, I put her on the ibuprofen and she caused gastritis, and I'm going to have to get a gastroenterologist to take a look at her and do an endoscopy and see if we can just, like, you know, find a source of bleeding and stop it. So I scheduled that on Monday. And then the GI guy says, well, we did the study, and she doesn't have gastritis. She's actually got a gastric lymphoma. And gastric lymphoma is inoperable, especially at age 82. So I went in on Tuesday morning, and I entered into her room, but before I entered, there were about 10 family members that were able to come right up to me afterwards and say, what was the test results? Tell us about test results. And I said, well, it's not good. I think she's got cancer, and it's not operable. The family all spoke in Chinese. They said to me, Dr. Wong, you can't tell her that. You tell her that she's got cancer, she's going to just throw in the towel. That's just devastating. Just don't tell grandma that she's got a gastric lymphoma. But I was trained as a Western physician. You have to tell your patient everything. Patient-centered conversations. Patient decision-making. So I went into this room really actually not having a clear choice, because she was really special. I go into the room, Mrs. Lee's lying down there, pretty comfortable. She said to me, she says, Dr. Wong, what did the test say? And then I kind of said, it's not so good. And then she kind of looked at me and says, you know, Dr. Wong, you've always been good to me. You've always taken care of me. Don't worry, I'll be okay. Are you okay? And I don't think I needed to tell her. But in that instance, she really cared about me, and she took care of me more than I ever take care of her, because I think she understood what it means to be a healer. And I still think about her. I still remember what it should mean to you. That first day you open up your paper or your email, and what you need to bring to your patients every day, because they'll probably give you more than you ever give them. So thank you for your time.